Good evening, ladies and gentlemen. Once again, I want to welcome you to today's evening meeting, which is on neuropathic pain, what a pharmacist should know. So as other members joining, let's probably give them 2 or 3 minutes. As other members join in, I want to probably ask you, have you received your vaccine? Kindly type in if you have received your vaccine. If it's the first dose, say yes, awaiting second dose. Kindly, on the chat box, let's engage. Perfect. I can see Dr. Marete says she's not yet gotten her first dose. Waiting second dose in 2nd July. Nick Juma, Jitesh, Daktari from Meru. Thank you very much. You've gotten your first dose. Yes, Dr. Nilesh, Dr. Shital Shah has gotten her first dose. I'm trying to see if there is anybody who's gotten the second dose. Oh, Dr. Rishi has gotten both doses. So, ladies and gentlemen, I await to get to 300 members or 705. Whichever comes first is when we're going to officially begin this webinar. I have received my first dose. Dr. James Mirori, second dose was supposed to be last week. Probably you get it. Dr. Jasprit, well done on both doses. Dr. Stephen Koech, you've not yet received your dose. So we need to ensure that you get your dose, Daktari. Dear participants, for those who are joining us, we are waiting for members to get to 300 attendees or 705, whichever comes first is what we are going to begin with. So in the meantime, I'm requesting all members to kindly, on the chat box, let's engage. Let me see if you've gotten your first dose of the vaccine, if you've not gotten the dose, or if you've gotten both doses of the vaccine, kindly drop it on the chat box for us to probably be able to understand and know if our Kenyan pharmacists are receiving the vaccine. 705 or 705 or 300 attendees, whichever comes first, we go ahead. Perfect. And once again, I welcome you to this webinar. It's co-hosted between PSK and Dawa Limited. So ladies and gentlemen, we are almost at 704 and 264 as we await more members to join. I'm kindly requesting you to probably to drop down a message on the chat box and let me know if you received your first dose of the COVID vaccine or you've not received it. Cecilia Tsikungu, welcome very much to today's webinar. I can see you eagerly waiting to learn on the topic. Dr. Magetu Jack, you got your first dose in the month of May. So, ladies and gentlemen, without further much ado, allow me to now go to the main part of that has brought us here today. Allow me to go to what has brought us here today. Today is a virtual webcast on neuropathic pain, and the main topic is what a pharmacist should know. It is a collaboration between the Pharmaceutical Society of Kenya and Dawa Group. Dawa Group is a homegrown organization, is a homegrown pharmaceutical manufacturer. It is Kenyan, and we are glad that we are co-hosting it with them today. We are going to have the webinar. The speaker for today is going to be Dr. Hanika Patel. She is a radiologist at the Aga Khan Hospital. This webinar shall run from 7 to 8:30 p.m. So a few ground rules. First and foremost is to thank you for participating in this session and to probably give you a welcoming remarks from the National Executive Council of the Pharmaceutical Society of Kenya, led by the president of PSK, that is none other than Dr. Louis Mashogu, and also the secretary led by none other than Dr. Daniela Munene, the CEO. Also, the participants remain muted during the entire course of this session. Please ask your questions via the Q&A tab at the bottom of your window. Questions shall be addressed by presenters on the Q&A tab. For PSK members, if not already done so, please do so. Subscribe on the PPB portal for these webcasts so that you can get your CPD points. And with CPD points will only be awarded to paid up members. For KPA members, the attendance list shall be shared with your officials for awarding of the CPD points. A point to note is that this session is being recorded, of course, for quality purposes, and it shall be made public on the PSK's YouTube page. So agenda for today, it's the welcoming and opening remarks. So as Dr. Hanika Patel prepares, to share her slide, allow me to stop sharing. Sir Jorge Santos, Mr. Santos from Dawa, are you with us? Mr. Santos from Dawa, are you with us? Perfect. Dr. Hanika Patel, without further much ado, this is your floor. I will allow you to share, and let's give you the chance to take over the floor. Karibu sana.
Thank you for the introduction, and thank you PSK and Dawa Group, and thank you everyone for logging in today. So today we'll talk through neuropathic pain, what the pharmacist needs to know, just generally what it is, how we can manage it at a community level. So I hope everyone can hear me and see my screen.
Yes, we can hear you loud and clear and can also see your screen.
Great, okay. So just starting off generally about pain. So what is pain? So pain is an unpleasant sensory and emotional experience. So it can be associated with actual or potential tissue damage or described in terms of such damage. So pain is very personal and subjective experience, and we'll see neuropathic pain in particular is very subjective. So it can only be described by a person experiencing the pain, and it exists when the patient says it does. So pain can be split broadly into two categories. So we have nociceptive pain and neuropathic pain. So nociceptive pain is also split into somatic and visceral pain. So it typically originates from the muscles, bones, joints. That's somatic pain. Visceral is mainly the internal organs, so the heart, liver, pancreas. So nociceptive pain in general is usually described as an aching, throbbing, or stabbing pain. Visceral pain, on the other hand, is usually dull, cramping, gnawing pain. For example, when people experience, pancreatitis or cholecystitis, things like that. But the thing about nociceptive pain is that the pain is localized and it usually resolves once the damage or the offending cause is healed. So nociceptive pain is usually also helpful to the body. It means it warns the body and protects it from the damaging source. Neuropathic pain, on the other hand, doesn't particularly serve a useful purpose, unfortunately. It's usually caused by a dysfunction to the nervous system, so the peripheral or the central nervous system. And unfortunately, because of that, it can be quite hard to treat, and it can be quite different for different types of people. So just going through the basic pain pathway and focusing on the neuropathic pain pathway. So anytime there's an injury or inflammation, it usually triggers the nerves to send signals to the spinal cord and to the brain, which then upregulates or downregulates the pain, and then sends it back to the parts of the body experiencing the pain, where something can be done. Neuropathic pain affects these nerves that transmit the pain signals from the periphery to the spinal cord or brain, and then back to the periphery. So it's basically, like I said, the central nervous system or the peripheral nervous system. So the nerve fibers themselves become damaged, dysfunctional, or injured. So it can be due to injury at any one of these points. And basically what happens is the damaged nerve fibers send incorrect signals to the pain centers, particularly in the brain. So it has been defined by the International Association for the Study of Pain as pain caused by a lesion or disease of the somatosensory nervous system. So it's a common condition, and it can be categorized, like I said, into peripheral or central. So central is a result of a central lesion or disease, such as a stroke, multiple sclerosis, or spinal cord injury. Peripheral neuropathy occurs from dysfunction or damage to a peripheral nerve. So those nerves that leave the spinal cord or the brainstem and go to the periphery. So a recent systematic review has on neuropathic pain. So it looked at studies across the world, and it suggests that the prevalence likely lies between 6.9% to 10% of the population. This is a whole population of who experiences pain. So this is quite high. And like I said, it affects different people differently. So it can have a negative impact on the patient's quality of life. So a lot of studies have looked at neuropathic pain and the levels of anxiety and depression that people experience because of it, particularly sleep disturbances. And this is much higher compared to patients with non-neuropathic chronic pain and patients without chronic pain. So we can see that it plays a significant impact, or has a high burden of disease in patients' lives. So how do patients describe neuropathic pain? It's important to try and identify it and differentiate it from the nociceptive pain. So they usually describe it as a burning pain, like an electric shock, pins and needles, numbness, tenderness, even when pressed gently, radiating, so it moves around and it's generally difficult to localize. And they can also say that they're sensitive to light touch. So things that they never used to feel, all of a sudden, they feel like they're experiencing it more. So like I said, it's a result of injury to the nerve fibers, and it can be due to anything. So it can be due to toxins, trauma, ischemia. It can be due to metabolic, so abnormalities in B12 folate. It can be infectious, or it can be due to compression. So you get positive and negative symptoms. So positive symptoms are usually altered or painful sensations, such as tingling, prickling, or pain, which is described as shooting, stabbing, or burning. Negative symptoms, so this is like diminished sensations due to a loss of the normal function of the nerves. So patients can experience allodynia, which is pain caused by a stimulus that normally does not cause any pain. It can cause hyperalgesia, which is increased pain from a stimulus that normally provokes pain and causes anesthesia. So pain in an area that feels numb. So normally the diagnosis is made by a good clinical history, followed by a physical exam. So the physical exam is a detailed neurological exam where they test the vibration sense, temperature sense, and just testing all the peripheral dermatomes to see what the issue is. Lab testing and imaging is usually used to help identify an underlying cause of the neuropathic pain. So moving on to some of the causes. So the ones I've highlighted in red are usually ones we see more commonly, and the other ones can also cause neuropathic pain. So most of the common causes are diabetic neuropathy, HIV-associated neuropathy, chemotherapy-induced nerve damage, and post-herpetic neuralgia. The other causes are also important and can be differentiated with a good clinical history. So although the causes of neuropathic pain vary, the symptoms the patients experience are usually similar because the underlying cause is damage to the nerves. So just going into a bit of specificity of the different causes of neuropathy. So in diabetic peripheral neuropathy, so it's a condition that affects quite a few patients with diabetes. The rate is estimated about 4 patients in about every 1,000. So symptoms of this type include numbness, tingling, poor balance, and pain. And the pain again is described as a burning or shock sensation. So the exact mechanism is unknown, but this is usually thought to be due to oxidative and inflammatory stress caused by metabolic dysfunction that we see in diabetic patients. So we normally have these metabolic derangements and vascular issues, which causes damage to the capillaries. And this leads to nerve damage, loss of sensation, particularly where the blood flow in the extremities is poor. So that's why we get heat more in the feet and in the fingertips. So the injury, they usually get injuries due to the loss of sensation. So they can knock onto corners of doors, corners of beds and not realize, but they're actually damaging the tissues and they're not feeling it because their nerves are damaged. And due to this, it can increase the chance of infection and subsequent gangrene and what we call diabetic foot. Another thing that we do see, particularly in the sub-Saharan population, is HIV-associated neuropathy. So it's considered the most prevalent neurological complication associated with an HIV infection. So this usually presents with a distal polyneuropathy. So that means it affects the distal parts of the limbs, upper and lower limbs, and it's usually symmetrical. And it can occur in both treated and untreated HIV infections. So there's different mechanisms for it. It can either be a result of injury by the virus itself, or it can be medication-induced mitochondrial dysfunction of the nerve cells. So risk factors of developing this include exposure to the antiretroviral drugs, increasing age, malnutrition, and certain genetic factors combined with diabetes. So this image is highlighting the range of peripheral neuropathy we see with HIV patients. Another thing that we see is either chemotherapy or radiotherapy-induced neuropathy. So it is the most common neurological cancer treatment complication, and it is dose-dependent. So these agents cause sensory nerve damage in the dorsal root ganglion. And they also describe their pain as numbness, and it's usually symmetric and distal with a glove and stocking distribution. So meaning it usually affects the hands, so that's the glove part, and the feet, which is the stocking part. And it can become worse as the chemotherapy is continued. So many cases, it reduces as the chemotherapy is discontinued. However, with certain drugs, it may persist. Another thing we see commonly is post-herpetic neuralgia, so shingles. So this is a type of neuropathy that develops when the herpes zoster virus is reactivated. So the virus remains latent in the dorsal root ganglion until the patient's immune system is compromised. So this can be due to increased age, HIV infection, cancer, immunosuppressive therapy. And at this stage, the virus gets reactivated. So it affects the nerves through sensitization. So it makes that nerve hyperexcitable, and it can cause that nerve to become damaged. So the pain is typically distributed along that spinal nerve, so the dermatome, or the ophthalmic branch of the trigeminal nerve, so which affects the face. So this affects the population at about 3.4 per every 10,000 patients, and it can cause significant discomfort and pain for the patient. Another thing that can cause neuropathy, which is sometimes also overlooked, is alcohol-induced neuropathy. So it can exert direct and indirect effects on the nerve function. So the direct effects of alcohol result from its metabolism to its toxic byproduct, which is acetaldehyde. Acetaldehyde produced in the liver is transported to the periphery, where it can form proteins, adducts, and cause nerve damage by oxidative stress. Also, the conversion of alcohol to acetaldehyde releases reactive oxygen species, which also affects the peripheral nerve physiology and function. Additionally, it can enhances protein kinase CE levels and activity in the dorsal root ganglia of nerves, and that can cause nerve damage. And again, it also impairs the Schwann cell proliferation and myelin sheath formation. So these are basically cells that line the nerve that help in maintaining the nerves, providing energy to the nerves. So alcohol interferes with this, and this also causes nerve damage. So normally with alcohol-induced neuropathy, it usually starts with pain and paresthesia initially. And then as the nerves get damaged, you start getting sensory loss and then subsequent weakness. So the diagnosis of neuropathic pain, what is the role of the pharmacist? So neuropathic pain is most of the time misdiagnosed and treated as musculoskeletal pain. So when the diagnosis of neuropathic pain is overlooked, the patient is usually treated inappropriately, leading to months and years of mismanagement, delayed diagnosis, and can impair the function of the patient. So the pharmacist can assist in the recognition of this condition, as it can manifest in heterogeneous symptoms, and can advise the patient to seek appropriate medical care and workup. So usually it's, you can usually relate the symptoms to what the patient has. For example, if it's, it's a non-diabetic patient who's now complaining of pins and needles, you're suspecting that now they're having nerve damage because of their diabetes. So the physician will usually perform a full neurological exam, like I said, and order various diagnostic tests to help assist in the assessment of the pain. So the neurologic exam, like I said before, is usually predominantly sensory testing for touch, pain, temperature, and vibration. So for example, let's just say we have a patient, BJ is a 37-year-old woman who is a frequent customer for her OCP. Today you see her in the analgesics aisle and you ask if you can help her. And she explains that she's had a pain on her right side of the body that has been going on for a while, and it's not been improving with over-the-counter ibuprofen. So the first step is to find out more about the pain. And like I said, so there's questions that you go through about trying to identify the type of pain, the impact on the life, and trying to localize or to identify what could be causing the pain. And she describes it as numbness and generalized with occasional tingling. So you're suspecting a neuropathic origin, and you refer her to see a physician to investigate for causes of neuropathic pain and appropriate management, as opposed to her just continuing with her OTC ibuprofen and not actually dealing with the problem that she's having. So the current treatment options for neuropathic pain, patients with neuropathic pain usually do not respond to traditional analgesics, so the paracetamol, NSAIDs, or weak opioids, because these do not focus on treating the type of symptoms associated with NP. So NSAIDs are usually reserved for inflammatory pain conditions, such as osteoarthritis, rheumatoid arthritis, where you get joint destruction, abnormal bone articulation, and associated inflammation. So essentially what they do is they try and reduce the inflammatory culprits. But for neuropathic pain, as we've seen in the physiology and the pathophysiology of it, it's not caused by inflammatory markers, it's caused by injury to the nerves themselves. So in the plan of care, it's good to discuss the expectations and the goals of treatments. So you need a clear understanding of the treatments that can be used and the schedule for monitoring and follow-up, because it's usually a chronic course and the patient usually needs a long-term management plan. And it's important to know that the pain may not likely be totally eradicated. So the patient needs to be counseled about this, set realistic expectations and achievable goals. So in terms of the pharmacological management of neuropathic pain, the first line treatments are usually gabapentin, pregabalin, TCAs, or SNRIs. So it's usually the patient can be offered either gabapentin, pregabalin, amitriptyline, or duloxetine, except for trigeminal neuralgia. So if the initial treatment is not tolerated or due to side effects, you can either switch between one of these first line medications, and if still not working, then you go to the second and third line medications. But it's most of the time, first line is enough. Tramadol is used for breakthrough pain, and it's not recommended for long-term use. The use of topical agents, and also botulinum injections. So that's usually for focal neuropathy and such as post-herpetic neuralgia, and also for elder patients. So all of the treatment guidelines from the NICE, Canadian Pain Society, and Neuropathic Pain Special Interest Group, they all recommend the same first-line treatment for neuropathic pain. So how do these medications work? It's important to know this so we can understand why the medications are working and also help the patient understand why this is useful for them. So just going back to the basics, the mechanism of action of the nerves, how pain signals can be transmitted from nerve to the brain. So we have the presynaptic neuron, the synapse, and the postsynaptic neuron. So basically when the signal or the action potential arrives to the presynaptic neuron, we have voltage-gated calcium channels which open, and they cause the calcium levels within this neuron to increase. And this stimulates the vesicles containing the neurotransmitter to be released into the synapse. The neurotransmitter crosses the synapse, attaches to receptors on the postsynaptic neurons, and it can either inhibit or stimulate this neuron depending on the function of that neuron. So for example, if it's a neuron, a muscle cell, or a gland cell, and therefore stimulates another action potential. So gabapentin and pregabalin, what they do is they inhibit the alpha 2 delta subunit of the voltage-gated calcium channels that we earlier discussed. So basically what happens is that it reduces the synaptic release of several neurotransmitters. So we have, in this diagram, we have a normal synapse. In neuropathic pain, this is upregulated. So this patient is experiencing more pain than they should. How gabapentin does, it blocks this effect and downregulates that sensation. So the onset of action is more rapid for pregabalin than gabapentin, and it has a narrower dosing range, so it requires less titration. However, both these medications are usually started at lower dose and titrated over 2 to 3 weeks. It can take up to 10 weeks of titrations to get it to the optimum dose. And it's important to let the patient know that they might not see the effects immediately. So it's important for counseling and also important for them to continue the medication with titration. So older patients are usually more susceptible to adverse effects. Therefore, usually start them at a lower dose. We normally do slower titrations for them. So a systematic review found that the numbers needed to treat for gabapentin and pregabalin for 50% pain relief was high. It was about 7.7 and 7.2 respectively. So these medications are usually well tolerated. Some of the side effects include dizziness, ataxia, and fatigue. So it's important to also counsel the patients on these potential side effects. Another first-line subcategory is the Triceratic Antidepressants. So not only is it used for patients with associated mood disorders, it can be used for any patient with neuropathic pain. So it blocks the reuptake of the norepinephrine and serotonin. It blocks the hyperalgesia from NMDA agonists, and it also has sodium channel blocking activity. So basically, again, it works in the synapse and helps with the pain pathway. The major side effects of these medications, though, is a serotonin syndrome, which are seen in the table. So they get agitation, confusion, tachycardia, dilated pupils, sweating, diarrhea, headaches. So this can be quite limiting for this subclass of drugs. The other treatments that are there, but are less likely to be used. So like I said, the opioid and opioid-like drugs are usually used for breakthrough pain and are not recommended for long-term because of concerns of misuse, overdose, and subsequent morbidity and mortality. Topical agents include capsaicin, lidocaine, and botulinum toxic. So like we said, usually for focal areas like post-herpetic neuralgia can be applied to help with that pain, usually for elderly patients. Other controversial medications are cannabinoids. It's not recommended, particularly in the UK and their guidelines, but in other countries, it's usually based on the patient. Non-pharmacological treatments are also very important because we said that this pain is usually chronic and can be multifactorial. So it's important for the patient to also adapt their lifestyle to help maximize their pain relief. So this can be physical, occupational therapy, rehabilitation, group support, or CBT if there is an associated depression and anxiety as a result of the neuropathic pain. Lifestyle change is also very important. As we've seen, alcohol, diabetes, all these things can cause or exaggerate the pain. So counseling on reducing alcohol intake, sugar intake, and boosting healthy nerves. This can be B12, thiamine, and folate. Very rarely procedures are performed. So these include nerve blocks, usually for therapeutic reasons, especially for back pain. You can also have peripheral nerve stimulation and spinal cord stimulation, but the evidence on this is less. So the counseling points that we need to remember for patients with neuropathic pain is we can see that we need a combination of treatment strategies to attain some relief for this chronic pain. It's important to understand that these medications require some titration, monitoring, and we need to, some of these patients may also have lots of other medications. So it's important to also understand how to manage those. Physical therapy, exercise, and psychological treatments are also important parts of the treatment plan. And it's important to set reasonable goals for pain relief. So knowing the pathophysiology, the causes, helps us better understand neuropathic pain. And it can also help the patient understand why not just taking acute pain relief will not help them for the future of tackling the underlying problems. So in conclusion, neuropathic pain is a quality of life that affects, is a condition that affects the quality of life of many patients. And it is a quite complex disorder. So it's usually difficult to treat effectively. However, as we show the treatment guidelines from lots of sources, usually there's preferred classes of medications, which are quite effective for these patients. So as highlighted, the treatments for the peripheral neuropathy include pregabalin, gabapentin, amitriptyline, and duloxetine as first line, with the amitriptyline and duloxetine, it's important to think about the side effect profile, particularly the serotonin syndrome, as well as the other things like the patient's age, other comorbidities and renal function, and also to address the underlying comorbidities because they could be the cause of the neuropathic pain. And it's also important to combine the pharmacological and non-pharmacological treatment. Thank you.
Asante, Dr. Hanika Patel. Thank you very much for the wonderful presentation that you have made. Asante sana. It is quite informative. It is quite well detailed. Thank you very much for taking your time. As you catch a breather, Dr. Hanika, we're going to go directly to one of our great partners, that is Dawa, a homegrown pharmaceutical manufacturer, and whom we support, whom supports us very greatly. And probably I've seen you've written cannabinoids amongst one of the probably drugs for use. So probably as Evans from Dawa sets up, and shares the screen, I will tell our members who are emailing us and asking for the presentation. These presentations are all available. are going to be available on our PSK website. Go to the PSK website, www.psk.org.ke/downloads. That's where you get all these presentations. They have been uploaded there on the PSK website. Ivan Sampagara, are you with us?
Yes, I am, and I'm ready. Let me know if you can see my screen.
I can see your screen, and I can see you and loud and clear. Thank you very much, Ivan. Take it over from now.
All right. Thank you, Getao, and thank you, Hanika, for the wonderful presentation. I'll take you through a brief presentation on some of our products offering in the pain therapeutic area. So my name is Ivan Sambagara, and I'm a product manager at Dawa Limited. So first, I'll take you briefly through a history of our company, just an overview of who Dawa Group is. We say that Dawa Group is a leading pharmaceutical manufacturer in East Africa, just as Getao has pointed out. And our commitment is to deliver the best value to patients through partnerships with scientific community, investing in quality and medical education. And that's the basis of Dawa participating in such webinars and interacting with the physicians such as PSK. So just to clarify who Dawa is, some people sometimes get confused about the two arms of Dawa, but this to clarify that Dawa Group is made up of two arms. This is the Dawa Limited, which is our manufacturing arm, where we manufacture and distribute pharmaceuticals locally and even in the East African and up to Central Africa region. And then we have the Medicel arm, which is an arm that imports medications into the local market. So we say that having both arms has enabled us to provide a wide range of pharmaceutical solutions to our healthcare providers. Our promise to the healthcare providers is to offer quality and effective medication, ensure an effective supply and distribution channel, and we have a manufacturing plant that is up to the WHO standards and is also ISO certified. Within Dawa, these are some of the key therapeutic areas that we are focused on. We have a wide range of cardiovascular products, which I'm sure most of you have probably interacted with our medical representatives and known our product offering. We are keen on getting into the diabetes space. That's within the year, we should be having therapeutic options within the diabetic space. You'd be looking out for that. And then we are also a big players in the pain and gastro setup. So again, I'm sure you've interacted with our reps and known some of our offerings within the pain and gastro setup. Today, the subject is neuropathic pain, and I'll delve into some of the offerings we have within this space. This is an overview of some of the pain products that we have. I'm sure these are familiar products, and won't focus on them. I'll just pick two to focus on today. Neuropathic pain, Hanika has discussed everything we need to know about neuropathic pain. I won't belabor the point, but key thing I wanted to highlight here is to show that one of our therapeutic offerings within the space of neuropathic pains, we have a gabapentin to address the neuropathic pain, and additionally, It's combined with methylcobalamin to address the demyelination of the spinal cord that normally occurs and is associated with the neuropathic pain. The product of focus today is one of the products, GABANAV, and we say that it's one of the solutions in managing neuropathic pain. As Dr. Hanika has pointed out, neuropathic pain would normally be intense in nature and difficult to manage, very patient-specific, and patients will describe their symptoms differently. Within GABANAV, it's a combination of gabapentin 300 milligrams with methylcobalamin at 500 micrograms. We say that GABANAV helps relieve pains, rejuvenates, and restores neurons. So on top of addressing the neuropathic pain, it has the component of methylcobalamin that also helps to rejuvenate and restores the neuronal damage that is associated with neuropathic pain. Again, this to highlight some of the key points of gabapentin. It's one of the components within GABANAV. It's proven and effective and well tolerated in the treatment of neuropathic pain. And its usage results in quicker relief of pain symptoms due to neuropathy. It's FDA approved, and we've seen that across several guidelines. It's also been approved for the treatment of post-herpetic neuralgia, prevents pain-related responses in neuropathic pain, and also the mechanism of action has clearly been pointed out with Dr. Hanika. Dr. Hanika also pointed out additionally that methylcobalamin, that's vitamin B12, would also be a solution in terms of helping addressing the neuronal damage that occurs. And methylcobalamin has been shown to act as a neuroprotector to relieve pain effectively and safely. Methylcobalamin enhances the sensory and motor functions of neurons to help in faster and better nerve conduction, hence prevents progressive nerve damage. It relieves burning sensation and loss of sensation and muscular cramps in diabetic neuropathy, effectively helping manage the neuropathic pain that patients will be experiencing. Indications and dosing. Again, this has been captured very well by Dr. Hanika. Diabetic neuropathy, post-herpetic neuralgia, alcohol-induced neuropathy, and neuropathic pain in cancer, and peripheral neuropathies as well. The dosing, it has a simple dosing of 1 tablet BD or TDS, but we say that the way the doctor prescribes is key to follow, because depending on the way the patient has explained to the doctor and the doctor aims in the treatment, they'll decide the appropriate dosing for the patients. This is a packaging. I'm sure it is familiar with most of you. Next, I'll talk about one of the treatment options we have in managing somatic pain. The subject today was neuropathic pain, but we say that at Dawa we have a number of options within the pain space. And I'll also take you very fast through the Asepa range of products in the management of somatic pain. So with Asepa, we say that causes of pain will be many and varied, but this answer that Asepa is giving is you're breaking the chain of pain. Asepa is a combination of aceclofenac and paracetamol, 100 milligrams and 500 milligrams respectively, to help manage pain gently. And they say that it's a combination that offers better efficacy and safety compared to when either of the drugs are given individually. So these are breakdown of Asepa. The components aceclofenac and paracetamol. Aceclofenac has been shown to be an effective analgesic and giving anti-inflammatory effect, and has a superior efficacy and a good safety profile. It has also been shown to offer to stimulate cartilage matrix, and it has a greater COX-2 specificity compared to diclofenac, just to confirm the reason for its better safety profile. Paracetamol, a widely used pain reliever. All of us are familiar with this, and it's safe and effective in most patients. The key indications for Asepa pain is the dental pain, post-surgical pains and strains, edema and swelling. It's recommended to be given as 1 caplet twice a day. That's the packaging for Asepa. The other presentation, actually Asepa range, the main components is aceclofenac and paracetamol, but we have other presentation that has additional components, like the Asepa SP now has serratiopeptidase additionally. And the serratiopeptidase component has anti-inflammatory effect, anti-edemic, and fibrinolytic activity. The key point is that it assists in reducing the swelling and microcirculation on top of the pain relief that is offered with the aceclofenac and paracetamol. Key indications is pain where there's also edema and swelling, post-surgical pain, dental pain, sprains and strains. This Asepa SP is also recommended to be dosed twice daily. We also have the Asepa MR containing clozoxazone. Additionally, that's a muscle relaxant. That's the addition on top of the diclofenac and paracetamol. The key indication is in cervical spondylitis, low back pain, fractures and dislocations, and sports injuries. We said the clozoxazone helps increase the mobility of the affected muscles on top of the pain that will be experienced by the patient. Again, the dosing is 1 caplet to be taken twice daily, and that's the packaging for Asepa MR. Finally, the last presentation of the Asepa that we have, we call it the Asepa Plus. And we also have the Asepa Plus DS. So the Asepa Plus contains aceclofenac 100 milligrams and thiopolpicoside as 4 milligrams. The Asepa Plus DS, the one which has thiopolpicoside, is the double strength, 8 milligrams. So it is thiopolpicoside is an antagonist of the GABA type A receptor function in the central nervous system, and it has been used for decades as a muscle relaxant and as an anti-inflammatory and analgesic. So the idea is to have combination treatments to effectively reduce the pain being experienced by the patient. The key indications for this is where there's low back pain, fibromyalgia, back and neck pain, spondylitis, and muscle pain, muscle sprain. 1 tablet should be taken twice daily, preferably with food or after food. This is the pictorial presentation of the packs for Asepa Plus and Asepa Plus DS. Thank you very much. That's the end of my presentation. So my last word is to urge you to recommend the DAWA range of products to your patients. We know that pharmacists form the last linkage in the treatment cycle, that after the doctor prescribes, it's the pharmacist that will be prescribing the medication. We really appreciate the support given from you, and we urge you to recommend the DAWA range of products to your patients. Thank you very much. Hand over back to Gechao.
Asante Evans for your wonderful presentation. So probably as Dr. Hanika prepares for the Q&A, and also as you catch a breather, Evans, is
Yes.
Santos from your end, the head of marketing, is he with us today?
Okay, I don't think he'll be commenting. I think that's the link he gotten, but I think he's in. Okay,
just wanted him to probably say hi to our members, because he's supported us quite a lot in matters conducting this webinar. Thank you very much, sir, from your end, the marketing department. So we go directly to the Q&A section, and I'll probably begin with Dr. Hanika. Dr. Hanika, are you with us?
Yes, I am.
Perfect. What specific painkillers should I take when I have neuropathic pain? That is a question that has been asked by Techno Spark 5 Pro. This is a similar name as guys from Alliance. They have to identify themselves. So the Techno guys also identify themselves with a brand of phone. Eh? They're asking what painkillers should they take when they have neuropathic pain?
Okay, so as said, it's not as such painkillers. It's about managing the nerve pain. So it's the first line medications that I spoke of. So the gabapentin, pregabalin, duloxetine, amitriptyline. And for breakthrough pain, usually low dose and short-term opioids is what is effective. NSAIDs and paracetamol is not useful for the neuropathic pain. It could be could have a bit of effect or placebo effect, but it's not long lasting, and the patient will bounce back to their original pain.
Oh, perfect. So the other question is from Dr. Dorothy Ayuak, who first on the chat box said that this is a wonderful presentation. Eh? She asked, how does B12 stroke or vitamin B complex help with neuropathic pain? Dr. Hanika, are you able to respond to that?
Yes, sure. So in fact, B12 deficiency in the diet causes neuropathic pain. So B12 is important, as also Evans has highlighted in his presentation, for the maintaining the nerves and the cells that are around the nerves. So it helps with the regeneration in case they're damaged. B12 is used in helping to regenerate them, basically to keep them alive. So having a deficiency in that can actually lead to nerve damage.
Perfect, perfect. Dr. Borura says very informative. Elizabeth Irongo is asking, some patients do not tolerate gabapentin and other first-line drugs. What alternatives can the patients use?
Yes, so there's actually been studies on this. So there's one that I came across from the UK. There's also guidelines from the UK, and it's they look at, because they don't do cannabinoid therapy, which is red line in some countries, they look at interventional therapies, and it's considered in select patients with refractory neuropathic pain if the first line medications fail to provide relief. So they have looked at spinal cord stimulation for these patients. And so far the trials have been quite successful, and other interventional therapies such as nerve stimulation, sympathetic blocks, and steroid injections. So these usually need to be referred to the neurologist for this.
Oh, perfect. Now, coming back to Ivan Sabagara, how is Asepa safe in the GIT compared to diclofenac, yet they may have the same mode of action? Mr. Evans Sabagara?
Yes, so the thing is, aceclofenac has a greater selectivity of the COX-2 compared to diclofenac. And that's the reason why we say it's much safer compared to diclofenac. Data has supported that its safety profile is better compared to diclofenac.
Okay, so thank you. As we proceed now, let me move to a question by the PR member, PSK PR committee member, Dr. Peter Ongwai. He asks, please comment on the use of carbamazepine in the management of neuropathic pain. Dr. Hanika?
Yes, so carbamazepine is just used for trigeminal neuralgia. So trigeminal neuralgia is a type of neuropathic pain which affects the trigeminal nerve. So that's one of the nerves around the head and neck, and it's only limited for that type of neuropathic pain. It's not usually recommended as first line for the other types of neuropathic pain that we've discussed today.
Okay, perfect. Ivan Sabagara, a question for you. David Wesasia is asking, recommended retail prices for Asepa? Evans, the recommended retail prices?
I will confirm you the exact pricing in a minute. So maybe you can proceed and then I'll just confirm for you shortly.
Perfect, perfect. So Dr. Hanika, this is a question for you from Thomas Okubasu. Which are the best option drugs for severe post-operative pains?
Yeah, so for post-operative pains, so we're talking more of the nociceptive pains. So those we're looking at opioids, which we downregulate, NSAIDs for inflammation, those sort of pains. The medication that we spoke of today for the neuropathic pain is not recommended for acute post-operative patients.
Okay, so Dr. Hanika, just back to you. Comment on the safety of mentioned muscle relaxants. And no, this is for Evans. Evans, hope you are attentive. Comment on the safety of mentioned muscle relaxant and the GABA/pregabalin on pregnancy and why titration is important.
So in pregnancy, just like, okay, hope you can hear me.
Yes, I can hear you loud and clear, Evans.
Yeah, in pregnancy, just like many other medications, we don't have enough data in this population, so it is not recommended. Some of them has been associated with negative effect on the fetal development. So maybe Hanika can also comment on that. The other question was on GABA-NAV. The other question was on?
The pricing. What is the pricing, the retail recommended price?
Okay, so for the SP, we have different, the Asepa, we have different presentations. And for the Asepa plain is around 260 shillings. And then the Asepa SP and MR is around 395. The Asepa in combination with the thiocholchicoside, the Asepa DS, it's around 800 shillings.
Perfect. Dr. Hanika, are you able to comment on that question?
Yeah, so I agree. It's not usually studies have shown it's not safe in pregnancy. And yes, like I mentioned, it's important to titrate, and also it's very patient subjective and also based on their comorbidities. So it's important to take all those factors into consideration.
Okay, perfect. Dr. Hanika, as we wind up, we're almost closing. We only left 2 questions. These other question is, how do we treat the addiction and or withdrawal of pregabalin, Dr. Hanika?
Yes, so usually like how we titrate in the treatment, for a withdrawal, we need to down titrate. So this is usually, it takes a couple of days or weeks where we have to slowly reduce the dosing, because an abrupt withdrawal can cause severe symptoms for the patient. And sometimes it's important to even do this, can be done as an inpatient based on the comorbidities the patient has. So some of the complications of abrupt or withdrawal symptoms include like dehydration, can even induce seizures, tachycardia, tachypnea, and it can also cause some suicidal thoughts because of the complexity of the issue.
Oh, perfect. Now, this is the last question before I move on to our chats. How useful is the reflexology in management of neuropathic pain?
So it's one of the non-pharmacological agents for the management of neuropathic pain. And like these non-pharmacological treatments, there's not been many studies into how effective they are, but some patients I've seen it works for them. So again, it's all about what works for the patient, and if it's helping them, then well and good. So yeah.
Okay, perfect. So a question from Tadudi. What do you do for patients that has used practically all painkillers for rheumatic pain but nothing works?
Sorry, could you repeat that?
That is on the chat box. What do you do for patient that has used practically all painkillers for rheumatic pain but nothing works?
So for rheumatic pain, so that's a bit different to our discussion we're having today. It's not quite a neuropathic pain; it's more of the inflammation that we see. So I think that might be in a different discussion.
Okay. I hear you. So what a timely presentation. That is from Neurologic. What a timely presentation. Why was diclofenac pulled out of the WHO and the Kenya Essential Medicine list, yet an effective drug? What is the alternative in pain management? Dr. Hanika, have you had the question?
No, sorry. I'm sorry. I'm not able to see these questions.
So the chat box, what a timely presentation. Why was diclofenac pulled out of WHO and Kenya Essential Medicine list, yet it's an effective drug? What's the alternative in pain management?
Again, I'm sorry, that wasn't the scope of this neuropathic pain. Diclofenac, as Evans said, is more for inflammatory pain. So I'd have to, I'm not sure if Evans can answer that, but I would have to look into that.
Okay.
Evans, are you able to dig into that question?
As I mentioned, I believe it's more about the safety aspects. And as I said, aceclofenac has greater selectivity for COX compared to diclofenac, specifically the COX-1, which lead to especially the GI side effects, which are associated with the NSAIDs. So comparatively, aceclofenac has a better safety profile if you compare to diclofenac. And I believe that might be one of the reasons for the steps taken against diclofenac. And then maybe another thing I would mention, the pricing on Gabanab, around 1,400 shillings to the patient. I think that I didn't answer earlier on.
Perfect. Now that is Dr. Dorothy Ayuaki is commenting and saying that currently the current alternative for that is dexketoprofen. Dexketoprofen is the alternative for diclofenac. And I see Dr. Balpreet is saying that I think diclofenac was associated with higher risk for acute heart attack, just as you've contributed, Evans. And the other one is the cost implication. The cost implication. Dr. Dorothea Yoakis is mentioning the cost implication. It's more, dexketoprofen is more expensive than diclofenac, but it is the best alternative due to the risks versus the risk benefits. So, Evans, we have a question for you. And what is the longest period that a patient with what is the maximum dose of Asepa in management of neuropathic pain?
Okay, I don't know if that was captured correct, because Asepa is not recommended in neuropathic pain. It's Gabanav that we mentioned is used in neuropathic pain.
Okay.
Yeah, and we said that, again, based on the doctor's assessment and the condition they are managing, with their review and the period of time that they've indicated, what I've seen is most precision will have like a month's prescription.
Okay.
And then depends on the review, the doctor's review.
Ah, perfect. Also, a person getting into the chat box, they're saying that diclofenac was removed due to the high risk of CVS activities. Perfect. That is great for tonight. Dr. Hanika, a question from Dr. Veronica Chege. What is the longest period that a patient with neurotic pain take tramadol?
So it's usually only recommended for a couple of usually just recommended for a couple of weeks, days to weeks, nothing more than that.
Perfect. So Dr. Maure has so it's a couple of weeks, asante. So what is the maximum dose? Comment on tramadol use, that has been commented. So let me see if there are other questions left for us tonight. No more questions. So as we wind up, so probably I'll give you a chance, Dr. Hanika, to give us, Dr. Evans, let's begin with Evans. Give us your parting shots for tonight, Evans.
All right, I would like to take this opportunity to thank PSK for making this possible for DAWA to participate in this organization and to bring together your members. We thank you for the support that the members have been giving us and passing the benefits of our products to their patients. We appreciate that, and we request that you continue recommending our products. We promise that we are offering good quality and efficacious drugs to your patient and at an affordable cost. So thank you very much, and we look forward to continued collaboration with PSK and the members at large. Thank you.
Asante. Over to you, Dr. Hanika. What is your parting shot for tonight? And first and foremost, thank you very much for always accepting to host our webinars at a very short notice.
No, thank you, DAWA Group and PSK. It's always a good opportunity to refresh on things we've learned before and also current studies that are going on. So I think my parting shot is it's important to hear the patient out, hear what they're going through to help treat them in the best way, to help identify the pain and the best management options for them, because it can be very debilitating for them. So thank you.
Asante. Mine from my desk is just to thank you, Evans, for the great coordination that you have ensured that we have this webinar today. Also, Dr. Hanika, taking your time to prepare this wonderful presentation. Asante Nisana for taking your time. Pass our regards to Sachi Mohindra, Jog Santos, Mr. Santos, and also Elizabeth, who's joined us albeit late, and also Dr. Ajay Patel. Pass our regards to them, and from the bottom of our hearts, we are much grateful. Also, members, before you leave, I'll probably make a few announcements that we are having our AGM. You have seen the notice for AGM. Kindly ensure that you register on time so that we are able to have a wonderful AGM and not much in the logins. So also, I want to thank all members who have joined in tonight, starting with Dr. Dagane from KEMSA. Thank you very much for making making your time, even though tomorrow is Eid, you've made your time. And probably to all our Muslim brothers and believers in the Islam faith, Eid Mubarak. Also, thank you very much to our senior members of the profession, led by the PSK Western Branch and Dr. George Matimbai, and also our NEC member, Dr. Peter Ongwai. Also, Dr. Jesse Mukuria, thank you very much, our senior members, for joining us today. We take it as an honor for you being with us. Also, the young pharmacists, we also appreciate you having taking your time to join us today. Dr. Masi Kibali, Dr. Mary Mundia, all the young pharmacists from wherever you're joining us, also Dr. Kevin Maore, also for taking and participating in our webinar tonight. And none other than Dr. Dorothy Ayoak, who's always on the back end to review our questions and also give responses that are not with us. Dr. Zainab, happy Eid. Tulilino na mwanzo amakweli lazima liwe na mwisho. Nataka kuwajulisha kwamba presentation iliyofanywa leo itakuwa presentations zote, all presentations that are made on these webinars are always uploaded on the PSK. From henceforth will be uploaded on the PSK website. So do not worry, relax. All these presentations are on the PSK website. Be visiting it. Now this one we shall share it and it shall be up on Monday. So ensure that you visit our PSK website, www.psk.or.ke. You'll get all our presentations there. CPD points will be shared 2 weeks after today. Na sina mengi ila kuambia muwe na usiku mwema. Ndugu zetu wanaoamini dini ya Kiislamu, Eid Mubarak. Kwaherini.